All right, we're live. Welcome, Crown
We are,
Council.
and we are alive too, which
We
is
are
a
very
bonus.
alive. It's happening. Grateful for everybody joining us. This is Crown Council Live, special edition, right? I mean, this is very special edition. So Steve is here. Pam, welcome.
Good day. Good day.
Grateful to be together. If you are joining us for the first time, every week at this exact same time, Thursday, 11 o'clock Mountain Time, we do Crown Council Live. This is our opportunity to connect with the Crown Council community and do a fun live show where we bring on guests, resource partners, people that have returned from all of the events that Crown Council and TOPS are running. But today is different. This is a special broadcast. Steve, will you introduce what we're going to do today?
Special edition today. So we do this every year. This is our annual coding and billing update webinar, if you will. So we're going to give a very concise insurance billing update along with changes that are being made for 2023 so you can be accurate for the year coming up, as well as we're going to share some common coding mistakes and miscoding mistakes and how to collect more from what you actually file. So this is going to be a packed hour. Our resident expert, Pam Peterson, president of the TOPS Institute, is with us, who is just a wealth of information in this area. And in addition to all the coding information, Pam and I are going to play a game today called What Do You Say When the Patient Says? So we've got sprinkled into the content today some of the most challenging insurance-related patient objections or comments. And Pam, with her verbal skills wizardry, is going to give you some of the best verbal skills tips on some of the more challenging situations. So it's going to be a packed 4 hours. No, it's not going to be 4 hours. We're going to motor through this in an hour. So get ready. This is going to be action-packed stuff here. So
Pam, is that a Pam Peterson bobblehead up on the shelf? We need to talk about that.
I think it is. I think it is a Pam Peterson bobblehead.
It's a gift from the TOPS team. So
nice.
Yeah,
I love it.
One of my favorite gifts.
Very cool. Pam.
Yeah. All right, Stu, anything else? We ready to go?
Ready to go. My only announcement, if you are attending the annual event with us, we need your RSVP ASAP. That is everyone's name and cell phone numbers who is attending the annual event. On the Crown Council website, you can go to the 28th annual hub and submit your RSVP form. We need it now. That's it.
Coming up next month.
That's right. We're inside, 60 days. We are. Yeah, it's happening. So,
all right, man, here we go. Coding and billing 2023. Can you believe it's already 2023, Pam?
Well, we have one more month. Let's finish out December.
Getting ready.
Slow and easy.
Get ready. Changes ahead. All right, Pam, hit us. What's new for 2023?
All right, let's talk about it. First of all, I want to thank you for allowing me to be the messenger. And I want to talk to you about where this starts and who's in charge. Well, there is a group called the CMC, which is and they partner really closely with ADA. And their responsibility is to look at all of the codes. And what I love about it is they're advocates for the dental practice, which is you, and for your patients. And so they'll remove old codes and enter new codes so that we can actually work really well together. And so for next year, because Steve is already ready for 2023, 22 codes were added and 2 were deleted. And I'm going to walk through all the new ones, and we'll talk about the 2 that were deleted. And then we'll also talk about some codes that are in your practice every day that could really use a revamp and a dusting off if you're not using them. All right, next slide, Steve. All right, so first is the tomosynthesis. Now, this is a big word, and what it stands for is a stationary intraoral 3D system. And a lot of practices have them. This has been around for a long time. They actually use them for mammograms. These new codes were entered. The 372 is for full mouth series. It's for bite wings. The 374 for PAs, and the 387 is for a pano. And with the 3D, three-dimensional imaging, what it does is it supports the clinician with diagnosing. And when you use 373 and 374, bite wings or PAs, on your dental claim, if you're submitting it, whether you are in network or not, you must place in box 29B the quantity. If you put it in the notes section, the person that's reviewing the claim are not going to look in box for notes for this. They'll look in box 29B. So place it in the right area for the quantity. Next, Steve. All right, there's two more, the 388 and the 389. These are stationary intraoral 3D system codes as well. The difference between these two and what I just shared with you is these are capture image only. And what that means is remote. So if a clinician is reviewing the diagnostic side of the practice remote, these are the two codes that you would use. So for bite wings, you would use 388. For PAs, you would use 389. And the same rule applies. Make sure you put the quantity in box 29B when using these codes. Now, what I just went over as far as the imaging codes, just because ADA and the code committee introduced them and they are approved because they are legitimate codes, doesn't mean that the payers are excited about it. It may take it may take them a couple of months, maybe a year to say, okay, we'll pay on it. Most of them that will pay currently it's for ortho. And you'll hear this because I'm going to sound like a scratched record. Make sure that you code what you do and do what you code. Don't change things just because insurance says that they're not going to pay for it.
Pam, there may be some people watching who do not know what a scratched record is.
Really? Oh, you know what? You're right.
Okay, deleted. Here we go.
All right, you better watch it. All right, so the two codes, think about that. No wonder the youth are looking at me like this. All right, the two codes that were deleted are D0351 and D0704. Both of these are photographic images, and one, it's the catch-all code. And the reason for them deleting these two codes is they said it's not specific based on what you're doing in a practice. Although they did not assign a code to replace the two that they removed, which is unusual, they did give us some options, which is what I'm going to go over next. So the next slide, Steve. All right, so these four codes are the option. So 801, 802, 803, and 804. Your dental people, so I know you know the difference between direct and indirect. Direct is outside of the mouth, indirect is inside of the mouth. So an example of 801 is if you are scanning a model or a diagnostic cast. If you're using 802, it's in the mouth. 803 and 804 mainly are used for ortho, but things are changing. This is when you're taking a profile image of the patient's face, that complete face in a 3D scan. So you would use 803 and 804 based on what you're doing. So these are the four codes that they recommend that you look at outside of the two that were deleted. Right, vaccine. So
I love this picture. Thanks, Pam. Thanks for putting this picture in here. Love it.
So vaccines have been entered into the mix, and there's been some chatter between the code committee and ADA and the Periodontal Association. And the goal is to pursue the whole person's health. And with them talking about it, you guys have been talking about this for a long time, which is treating the whole person and not just teeth. Next slide, Steve. So the three codes that were added, and it starts from the American Periodontal Association, the American Pediatric Association, are the 1781, 1782, and 1783. This is the HPVAC, and it's done in 3 doses. Now with the HPVAC, there's an age start and end, and they recommend anywhere from age 12 to 14, and it ends about 18 to 21. Now, although I'm talking about the HPVAC season, behind this is there's a direct correlation to HPV and oral cancer. So they thought when we talk about the whole person, patients come see you a lot more than they go see their primary care physicians, hence why it was introduced into dentistry. Now, I just gave you some great information, and now I got to tell you that if your state has not approved it, we don't have permission to go ahead with this just yet, but they are ADA approved codes. There are only 2 states currently that have are approved for HPV vac, and that's Illinois and Oregon. Next slide, Steve. The next vaccines are COVID vaccines. And there's been some chatter about this. Who was approved to do this in the very beginning were pharmacists. And another dentist stood up and said, if a dentist can do an alveolar block, they definitely can administer a vaccine. So if you choose to do this in your practice, these are the codes that you would use. 1708 is for the series. 1709 is for the booster. And that's for 1710 and 1711 is Moderna. One is for the series and one is for the booster. And then 1712 is a booster, it's Janssen. Now, there's 2 more, which are for pedo. Would you advance the slide, Steve? This 1713 is for peds, and this is the first dose. 1714 is the second dose. Now, if you choose to do this in your practice, there's a simple process that you would have to go through to get certified if you choose to administer a COVID vaccine in your practice. Okay, next slide. There was one perio code that was introduced prior to D4286. There was one code for replacing the non-resorable barrier and removing. The code committee felt that there were 2 procedures, therefore it needs to be 2 codes. And if there's 2 codes, guess what? You could actually charge for it. So D4286 is the removable of the non-resorable barrier. Next slide, Steve. There are 4 implant codes that have entered the mix. The first one is 6105. It's the removal of an implant body that doesn't require bone removal or flap. So if an implant fails and doesn't have to be surgically removed, this is the code that you would use. 6105, 6106, and 6107 are both guided tissue regeneration. And the difference between the 2 is one is a resorable and the second is a non-resorable. So whatever material that you are using in your practice, if this is something you do, you want to make sure that you apply the correct one, if it's resorable or non-resorable. The next one, there's one more, Steve, if you can go back one more. The 6197, that's a replacement of the restorative material to actually close the access of an opening screw retain implant supported. Prior to 6197, there was a catch-all code. Okay, next slide, Steve. All right, 7509 is marsupialization of otogenetic cyst.
Wait, you got to say that word again. What is it?
I knew you would do this. Marsupialization.
That's a tongue twister.
I'm going to give you layman's terms. Marsupialization of otogenic cyst. What that means, you're going to say, Pam, you should have said this in the first place. And I know you're dental people, so you're not going to get grossed out. If a patient has a pocket or a cyst or a boil and it requires to be drained in order to heal, this is the code that you would use. Most don't know about 7509. There was a code prior to, and it was deleted. But with 7509, it'll prevent you from making an in-house code and doing a complimentary or making up a price. There's actually a code for it. So Steve, you're going to get a test on that word later.
I will. I'm going to practice my pronunciation.
Okay. 7956 and 7957 are both guided tissue regeneration. In the area between the 2 is one is resorable and one is non-resorable. You would use these codes if your patient was having like a sinus lift or a ridge augmentation, or after a tooth extraction, preparing for future restoration. So those are the codes that you would use, and they're per site. Next slide, Steve. All right, so we talked about all of the updates as far as all of the new ones that have been entered, and then the 3 that the 2 that were X'd. Now we're going to talk about codes that are at our fingertips that are in place that sometimes we forget they're there. And so we're going to do a little checkup to see where we are. Now, as we go through these codes, I want you to think about your practice and it's like, yep, we're doing it, and give yourself a high five. And if you're not doing it, say an O, and the O stands for opportunity. All right, Steve, next slide.
All right, so here's our first one, Pam.
All right.
Here's our first quiz. What do you say? So this is a quiz for everybody because these are common questions that you hear every day that have to do with insurance. So what do you say when the patient calls and asks, do you take my insurance?
All right, after this,
Pam?
okay, I'm going to be the team member that wasn't listening for training. How's that? And I'll let you be the trained team member.
You got it. So yeah, do you take my insurance?
I mean, it depends. What insurance do you have?
MetLife.
Nope, sorry.
Okay, bye.
Bye.
That was beautiful, Pam. Don't follow Pam's advice on that one. All right, let's try that again, Pam. You be the patient.
Do you take my insurance?
That's a great question. Again, if I were doing this on the phone again, my name's Steve and yours is? Pam. Thanks so much for asking, Pam. Can I ask you what insurance you have? Who do you have your insurance benefits with?
I'm insured with MetLife.
MetLife. Great. Yes. Well, Pam, good news. You're in good company. We have a lot of patients who have MetLife benefits.
Oh.
Now, we don't happen to be contracted with MetLife because we're an unrestricted provider, which means we can work with all types of insurance. Would you like to know why our MetLife patients choose us?
Absolutely.
So what they tell us is that when they look at all the other choices that they have, they choose our practice because of Dr. Smith's amazing clinical expertise and our great patient service. In addition to that, we will file all of your insurance claims for you and do everything we can to help you maximize your insurance savings. How does that sound?
Sounds great.
So Pam, what would be the best day of the week for you Monday through Thursday for your first appointment?
Wednesdays work best.
All right. So that is, that was rapid. And here's it all spelled out. So let me just dissect this real quick. Those of you that have spent any time with us at all at the TOPS Institute, we work on case acceptance verbal skills all the time. This is one of the more complicated ones. I'm not a big fan of scripts, and sometimes there are situations that require learning somebody else's language so you can make it your own. So first thing you do is ask, obviously, who they have their benefits with. And then you give them the comfort of knowing that there are other patients just like them that have those same benefits, but only if it's true. It's got to be true, right? So good news, we have a lot of other patients that have benefits with whatever that company is. And then I say, I'm going to tell the truth, which is we don't happen to be contracted with MetLife because we're an unrestricted provider, which means we can work with all types of insurance. Would you like to know why our XYZ patients choose our practice? That's the question. That's the real key, right? Because that's where you get the permission to move forward. And then I do what we call overhear psychology. So what our patients with your benefits tell us, Pam, is that they choose our practice because of Dr. Jones's amazing clinical expertise and our great patient service, or something along those lines. In addition, we help all of our patients file for their benefits. We help them maximize their insurance savings. Would you like to go ahead and schedule your initial visit? And then I'll go ahead and straight into scheduling their visits. So all of that works a lot better than saying we're not in network or we're not contracted, because the only thing they hear is no. One of the activities I'd ask you to do as a team is look at how many patients come to your practice that have benefits with which you are not contracted, and ask yourselves, why did they come to your practice if you're not in network? And that will give you the answer to this question. It's not a prerequisite to be in network for a patient to come to your practice. We always have to keep that in mind. And it takes some skill to be able to explain that to people, because many patients think they can't come, that they don't have a choice unless you're in network. So That tip, this one is worth memorizing and really practicing because it's one that you'll use a lot. Okay, Pam.
All right.
Coding
next up-
habits that will get you in trouble.
All right, let's take a look at them. All right, next slide, please. All right, so first, it's why is it never a good idea to alternate 4910 and 1110? And I know you know the difference. 1110, it's a healthy mouth. 4910 keeps the disease at bay and in remission. These patients have gone through non-surgical gum therapy. They have gum disease.
But Pam, insurance will only pay 4910 twice a year.
I totally understand that, Steve. Where we get in trouble is you go against your doctor's standard of care because insurance is dictating. Now, we recommend that you always code what you do and do what you code. So when you submit 4910 and it is downgrade, and insurance will refer to it as remapping, call it downgrade because that's the slang. And so when they downgrade to an 1110 in the notes section, all you have to do is say, please pay the allowable amount towards the procedure. And that way you are an advocate for your patient and you're adhering to your standard of care.
So you're always billing 4910 and you add the note in the note section.
Absolutely. Absolutely.
Okay. No alternating.
No alternating. We want to retrain the insurance company. All right, so if I were to give you a pop quiz and we talked about exams and how many exam codes are there, I bet everyone would get an A+ on the top 3 frequently used. And there are 3 that we don't use as much. So the frequently used that you would get an A+, which is your periodic exam, your limited exam, and your comprehensive exam. There are 3 that don't get enough love. And so let's talk about those 3.
Love your insurance codes.
Is that going to be another book?
It may.
All right, next slide. All right, let's do the first one, which is the D0160. This is a code that's followed by a comprehensive exam. It's not a standalone code, which means you can't routinely use this. You use it for a second evaluation. Example is a patient have come in and there's a comprehensive exam performed, and the doctor needs more time to really come up with a plan for an extensive treatment plan. An example would be TMJ. You would schedule a follow-up creating an in-house code that's made up, and then a no charge fee. There's actually a fee for a second evaluation to allow the clinician to put a plan together for the complete treatment plan because it's a complex treatment plan. Now, there are some frequency limitations on this code. Most payers will allow twice a year, every 6 months. If it's used more than that, most payers will deny the claim. And the good thing about it is there is a code for a second evaluation. So that's the D0160, and it's an exam code. Next slide. The next one is the D0170. This is a reevaluation of an established or new patient. And this is when a problem isn't definitive, which means treatment hasn't been rendered, or the doctor needs to do a follow-up appointment. A lot of times the 170 gets confused with the 171. The 171 is a post-op code after a tooth being removed or some type of surgery or feeling where you bring them back. So 170 is different. It's an exam code. And if the doctor needs to see the patient again after followed by a periodic exam or a comp exam, this is a code that you would use. Now, the example that I would use for the 170, it involves tissue or trauma. So if, say, if an adult or a child hurt themselves on the playground, they broke a tooth, they come in and the doctor does a limited exam, did the necessary pictures, came up with a plan to get the patient stable, and would like to see them a second time, this is a code that you would use instead of creating a code for look-see. You would use the D0170. Next slide, Steve. All right, so the D0180 is a comprehensive periodontal evaluation code for new and established patients. This code is a standalone code and cannot be used in conjunction with the D0150. Designed for patients who present symptoms or at high risk factors for periodontal disease. And some of the symptoms is if they smoke or have any of the inflammatory diseases like hypertension, diabetes, cholesterol, to name a few. This is a code that you would use for these patients. Now, there is some limitations on this code as well, just as there is with any of the codes that I'm going over today. The D150 has a lot of restrictions. It's anywhere between 3 years or 5 years. The 180, most payers will allow you to use this code twice a year. And the practices that our coaches are working with, they alternate this code using a periodic exam in between the patient's visits. Now, when using the D0180, you must make sure that you send complete documentation to insurance, whether you are in network or not, if it's on behalf of the patient. And what I mean by that is a complete periodontal assessment, which is 6-point measurements. If you do WNL, like within normal limits, you will get rejected. It must have documentation of bleeding points, furcation, gingival attachment, and a legible series of x-rays, and that must be submitted with the D0180. All right, next slide, Steve. Next slide. There's 2 more that's unutilized, and one that you're very familiar with is the D0220, which is a PA, and often the D0230 isn't used. And when practices are using the 220, which is a PA, they will submit this for 1 PA, 2 PA, 3 PA, and then often they'll wonder, why did insurance only pay for 1? Well, the 230 is for an additional PA. And so when you use 230, go to box 29B and put the quantity. But if it's additional, you have to use 230 and not 220. 220 start, 230 are additional. These are small errors that will have a huge pay off for the practice and allow you to charge and receive funds for the things that you're doing in your practice instead of adjusting them off. Next slide. All right, buildups. I know 2950 is frequently used and 2949 isn't. Now, the first thing I want to say about buildups, I know that a lot of payers will send you this love note and share with you that this is inclusive to the crown, which means it should all be packaged. We still want to make sure that you separate. They're 2 separate procedures. So code the crown and code the buildup, regardless what insurance is dictating. Now, the difference between these 2 codes is 2950 is for retention and 2949 is to restore the tooth. So if the tooth needs to be restored from having endo, you would use 2949. And if it's for retention, which is most of them are, 2950. Utilizing buildups, it is really important. If you were placed in the notes section, facts, not emotions, the person that's looking at your claim will look to see the reason why. We want to make sure that we give the payers an opportunity to reimburse you. So make sure that you place in the notes section the reason for the 2949 and or the 2950. All right, Steve. Next is silver diamine. And I know that lots of practices are using silver diamine. And there is a difference. Sometimes they'll use just the 1354, which is active carious lesion. But the 1355 is for high-risk sites. And so one's for prevention and then one's for active. You have to make sure that you code the correct one. And in the narrative section, in the note section, place your reason for using silver diamine. And the good thing about it, it can be used in conjunction with the 1206, which is fluoride, whether it's for varnish or not, but always place in your notes section. The codes that I've gone over, it's always good, and you'll hear me sound like this. I can't say a scratch record. Now you have to tell me what's hip to say. want to make sure that you trust but verify. Always get a breakdown of the patient insurance savings so that it puts you in a good position to give them an estimated cost that's due from them. All right, next slide, Steve.
So Pam, on that one, you can use both so if you're administering a fluoride treatment and you're using silver-diamine, you can use both codes.
Absolutely.
Excellent.
Yes. And especially with the 1355, where it says patients are high risk for cavities, I would always in the notes section just will get the person who's reviewing the claims attention.
Got it. Hey, Pam, you ready for our next, what do you say when the patient says quiz?
Yes.
All right, this is for everybody. What do you say when the patient says, will my insurance cover all of this?
Will my insurance cover all of this?
Wait, I'm going to ask you first.
Okay. All right.
You get to be the average team member, Pam. Will my insurance cover all this?
Okay, I'll work on being average. It's kind of up in the air, you know. Sometimes they will, sometimes they won't. Everything's an estimate. Most of the time they don't.
Thanks.
You're welcome.
All right, let's do it the right way.
Hey, will my insurance cover all of this?
You know, that's a great question, Pam. It sounds like what you're really interested in is making sure that we do everything we can to maximize your benefits. Am I right?
Yes.
Very good. So what we can do is based on what we know about your insurance, we can give you an estimate of what your insurance savings will be so that you will know what your portion is. Would that help you give you some peace of mind?
Oh, yes, it would.
Okay. So the key to that one is to go down the road of to feedback to say, it sounds like what you're interested in is making sure that you maximize your benefits, which is what most people are concerned about. Pam, let's take it one more step and let's say that you're not going to do it unless your insurance really does cover everything.
Right. I mean, thank you for all of that, but I only want to do what my insurance will cover.
Gotcha. You crazy? No, I wouldn't say that.
Kind of.
All right. So Pam, just so that we're on the same page, in the event that there are things that you said you wanted that your insurance does not cover, then what do you want to do in that situation?
Oh, well, I care about my teeth. Well, I want to know about it.
Okay.
Yeah.
So then would it make sense? We'll give you the best estimate we can so that you'll know for the things that you really want to do, what your insurance savings is. And then you'll always be in a position to make a well-informed decision and figure out how that works in your budget. Make sense?
Makes sense.
Okay. So we could keep cranking it up, but the key to that one is to say, in the event that there are things that you said you wanted, okay, and that's the key part. In the event there are things that you said you wanted that your insurance doesn't cover, what would you like to do in that situation?
Right. See, when you asked that question, I can tell you what it felt like for me. Although we're still practicing, sometimes it's hard for us to articulate what we're really wanting to say. And you made me feel like that. What I really wanted was to be in control and not be surprised.
You got it. And that's for most insurance objections, that's what the real issue is. I don't want any surprises, and I want to be the one making the decisions. So again, there's the thing that's fascinating about a lot of these situations is sometimes one word, sometimes 2 or 3 words can change the whole direction of the conversation. Mm-hmm. So in this case, it's things that you said you wanted. Mm-hmm. That's the key to this piece. So in the event there are things you said you wanted, the insurance then doesn't cover, what would you like to do in that situation?
Mm-hmm. Exactly.
All right, next, Ohio. Wait a minute, what?
Well, we're not going to Ohio.
Oh, well, it says welcome to Ohio.
Well, let me tell you about that. One of the things that when I say I'm talking about we subscribe to Ohio, only handle it once. We find it's so much better to do things right the first time. So it affords you to do all those other good things that you enjoy doing, which is connecting with people. So we're going to go through some nuts and bolts of checks and balances of how you practice Ohio. Do it right the first time so that you get the results that you want. So let's walk through Ohio, Steve.
All right, welcome to Ohio. For all the Ohio folks on the line, here we go.
All right. So the first is your claim, and this is applicable whether you are in network or not. If you are filing on behalf of your patients, you want to make sure that you're using the correct claim. And it's always like on the very bottom left, you see where it says 2019 American Dental Association. That's the correct claim. A lot of times when you submit a claim electronically and you have not updated, the insurance company will not call you. They won't send you a letter. They'll just reject your claim. So you want the correct claim. Now we're going to talk about some other key things that are attached to the claim. Number one, which is box 33, if you are doing any type of replacement, such as a bridge implant, you must include the missing teeth. The doctors that are working for the insurance companies, their eyes are trained to go to boxes, not to look at your entire claim. And if I were to think about what they use as far as metrics that are important to their company, it would be volume, not how much that they can pay you or deny. It's volume. How many claims can they crank out? So you want to make sure you place it in the correct location so that their trained eye will go to the right place. Box number 35, additional information, which is what I've talked about today, which is where you place your narrative and your remarks. And you want to make sure that it's facts, easy to read and simple, not a long, lengthy story, which they don't give you a lot of room anyway. So the next slide, Steve, is 36. It's signed. Everyone that is listening, I know that you have an internal and external financial guidelines. When patients come to your practice, you share with them what your guidelines are, and there is a signed financial agreement. And on that financial agreement, it states that they will be responsible for their portion. If you're filing insurance for them, that they gave you permission to file insurance. So box 36 and 37, most of the time you'll see signature on file. So you want to make sure that you have a signed financial agreement from your patients. The 37 gives us permission to file on behalf of the patient and for the payment to come to us. Box number 58, the treating dentist, the dentist that performs the treatment, goes in box 58. Now, if there's a doctor that owns the practice and he or she did not treat the patient, their information doesn't go there. It goes in the area of where the practice information goes as far as the entity. But the treating dentist goes in box 58. And what's not a bonus, there should be an NPI, a national provider identification number for the practice, and a national provider number for the treating dentist. And their NPI goes right underneath the treating dentist. And I know you know that, but I just wanted to make sure that we're practicing Ohio. All right, next slide. There are, and you can advance it, Steve. There are some key things as far as, you can go ahead and put them all on there. There's some key things where what we look at every single time that when we're in a practice. And the first thing is we want to make sure that the insurance claim is filled out completely, that the correct procedures are listed. You want to trust but verify, that the claim is submitted within 24 hours. Don't batch them and let them just sit there. Go ahead and practice Ohio, only handle it once so that you can start fresh the next day and not doing yesterday's work. Correct documentation sent with the claim requires a PA, or if you're using the D180 like we talked about earlier, send the correct documentation the first time. And then you also want to make sure that you review the claim submission status, which I'll go over shortly. Next slide. Here are the 3 reports that our coaches check every single time they go into practice. They always check, they run these reports, and it doesn't matter what software you have in your practice. The language may be different, but the reports are the same. which are insurance claims not sent, procedures not attached to insurance, and secondary insurance claims not sent. Whether you take secondary or not, we recommend that you run that report as well. The goal is when you run these reports, do not print them. You just want to run them and view them. When you run these reports, the goal is for these 3 reports to be blank. You don't want anything on the reports. And we recommend that you look at this daily, not weekly, not monthly, but daily, so that it affords you to have happiness the next day and you're working on the next of yesterday. Next slide, Steve. The submission status. This is really important, and the same rule applies. It doesn't matter what software you're on. If you are feeling like this woman, where you're looking to think, where is my claim? Did someone steal it? No one stole it. There is a process that you have to make sure that everything is going right within your software. There's a validation report, and the validation report will send you a warning first if the claim is missing. It scrubs your claim if the claim is missing some information. And if it's not taken care of quickly, it will reject. So it won't go anywhere. It won't go to the insurance company. If the validation is a thumbs up, the next step will be a confirmation. The last step will be a clearinghouse. When you get clearinghouse, that means your claim is gone to insurance. And I know many of you will follow up and the insurance company will act like I've never seen it before. You always want to make sure that you keep your records of when something was sent and follow up timely. We recommend within 2 weeks. If you sit everything and you process every about 2.5 weeks, your claim should be on its way back to completed and on its way back to you. So I'd always trust but verify and then check. All right, next, Steve. All right, here are some do's and don'ts, and you are all Eagles, so I know you're like, Pam, I don't even know why you're going over this with us, but just in case, I'm going to go over it anyway. Never include anything that's not documented in the clinical chart. If it's in the clinical chart, that's what you include, and it's always facts, not emotions. You want to take the time to do it right. Use proper spelling, punctuation, and grammar. Make it easy for the person that's reviewing your claim. Avoid handwritten narratives. This will make sure that it ensures that the claim is legible. And then you want to omit irrelevant, unnecessary comments like the emotional part. You don't need to put a story, just put the facts on the actual claim. All right, Steve.
I love this slide.
Now, this is when, sometimes when you're talking to someone and they're just mailing it in as far as the insurance company and they're not in a good place. I mean, if you sat in a room full of people all day and you did the same thing, you may have an off day as well. We are Eagles, so never use aggressive language or statements to challenge the expertise of the consultant. In Texas, we believe that you get more bees with honey. So you want to make sure you present facts and not fight with the person who is in charge of getting your claim back. Use their name, use your verbal skills, use their name, talk to them, thank them, and then they'll wake up and actually work for you. You want to include clear diagnostic quality radiographs, and please don't send your originals and label them. And I know you're thinking, well, they should know this. Make it easy for them. Like I said, they are measuring volume, not accuracy, and not how much they can pay or deny. It's volume. How many per day? All right, Steve.
All right, Pam, here's your last. What do you say when the patient says, I want to know what my insurance will cover first?
Okay. Well, you want to know what your insurance will cover first? I mean, well, there's a number of things you can do. You could actually wait and do it later, or yeah, or maybe we could just submit something to insurance and see what they'll cover. It may take a while though. Is that all right?
That was horrible, Pam.
It was. Let me say my job. All right, Steve, I want to know what my insurance will cover first.
Gotcha. So Pam, it sounds like you do not want any surprises. Am I right?
You're right.
I am with you. So based on what we know about your insurance savings, your insurance company has shared with us that your insurance savings for this particular procedure, the fee's $1,500, Your insurance savings will be 500. So your portion would be 1,000.
Okay. Okay.
How would you like to take care of that?
Can I use a credit card?
That'd be great. Now, here is the, again, these can go in a lot of different directions. The best we can ever do is an estimate. Now, if you want to press me a little bit more, Pam.
I mean, so if it's just an estimate, so you're saying it'll be 1,000, but you really don't know?
Yeah, based on the information that your insurance company has provided, that is what the estimate is of what your insurance savings will be. Does that make sense?
Yes, it does.
Now push me even harder.
So, I mean, but what if it's more than that? I mean, I don't know about that.
Yeah. So it is, we can go ahead and submit it in advance. And what they will send us back is an estimate of what they will cover. So what I would suggest, we can give you, this is the information we can give you. Your insurance company works for you, Pam. You're welcome to call them and see if they'll give you any more information. But as far as we know, this is what your estimated insurance savings will be. Make sense?
Okay, fair enough.
So if somebody is just absolutely adamant that they want a pre-authorization is not a guarantee of payment. And this is the real dicey proposition about having this conversation. I can do it the wrong way and get into the yes, but battle, but that does not work. So the best way is to help the patient understand that the best that all of us can do together is an estimate in advance of what the insurance savings. We've used that term multiple times today in the last hour, your insurance savings. That's our preferred terminology, is your insurance savings, the estimate of what it will be, and helping them understand that even if you do the pre-authorization, it's no guarantee. So best we can do is work with the estimate and move in that direction. So this one, I think the more people understand about insurance, a pre-authorization, again, is no guarantee of payment.
They take a long time. The patient will go off and take 5 or 6 trips before the pre-auth or the pre-D returns. And it's because it's a low priority for the dental insurance company. That's why it takes 4 to 5 weeks, or if not longer.
So the other alternative to that, if they're just adamant about the pre-authorization, I would say, great, Pam. So it sounds like it's something you'd like to move ahead with pending the pre-authorization. Why don't we go ahead and do this while you're here and it's convenient? Let's go ahead and schedule the appointment now so we can coordinate it, and we'll schedule it far enough out to give the pre-authorization time to come back. And if that is anything different than what you and I have talked about, then I will call you so we can determine what to do next. Make sense?
Makes sense.
So I'd go ahead and schedule it. And if you have to schedule it 2 months out, schedule it 2 months out, but go ahead and get it on the books so you're not chasing the patient. Because if you call them when that pre-authorization comes back, they will have forgotten what you're even talking about. Mm-hmm. So a couple of tips on the verbal skills side of insurance. So thank you, Pam, for your expertise today on the billing and coding. We have a couple of resources for you to help out in your billing, financial arrangements, and coding efforts. First, as a part of your Crown Council membership, we highly recommend that everybody do a fee analysis every year. Here's how you request that. Is you go to crowncouncil.com. I'll go there right now, and you will log in to your directory. So everybody who is part of the Crown Council has a directory, go to your premium member hub. And then right here on the right-hand side, it says request 2023 fee report. And what you can do there is go ahead, fill in your name, all the requested information, your email and your zip code. You can submit that and it will come back to you. We'll email your fee report back to you. And the TOPS coaching team is available with questions. There's a video on this site that'll explain the fee report if you have questions about it. And you're always welcome to reach out to us for specific situations. So if you do have questions regarding what we've talked about today, you can email answers@totalpatientservice.com with any insurance questions, as well as if you go to totalpatientservice.com, there is a live chat function that our team can at least help get you initially pointed into the right direction. So those are a couple next steps. Here's some other additional resources. There are a lot of practices who are rethinking their relationship with insurance, probably more so today than we have experienced in 30 years. So we have created a special course called Should You Be Insurance Free? And the reason the course title is a question is because it should be a question, not the answer. So what we go through in this course is all the important questions that you need to know the answer to before you make any change in your relationship with insurance, whether you want to go in network or out of network. We'll walk you through those specific questions. It's a strategy session, 2 days. We recommend the doctor and key team members, and we do a deep dive into your practice strategy as it has to do with your relationship with insurance. So all of that course information is at totalpatientservice.com. Some other events coming up. Stuart mentioned the Crown Council annual event coming up next month, end of January in Salt Lake City, Utah, at one of the most beautiful venues in America, at the Grand America Hotel. So there are some limited seats available. And you can, if you go to the Crown Council website again, all the information is there. In addition, we will launch we'll launch the Young Dentist program for 2023. This says 2020, but it'll be 2023. That will be launched at the annual event. And information on the Young Dentist program. So anybody out of school 5 years or less is welcome to attend. It's an amazing experience. You can go to youngdentistprogram.com, or again, it's on the Crown Council website. Total Immersion, our next in-person session, which we consider to be required for every Crown Council practice. It is basic training in patient service and case acceptance. The next in-person event will be in Dallas, Fort Worth, March 2nd through the 3rd, an amazing experience, as well as the No More Hygiene course, April 14th and 15th in Dallas, and our Leadership Academy, the end of April. So a lot going on.
Hey, that's a lot of stuff.
A lot of events to engage with your team to take your practice to the top.
Nice.
2 more resources. One, a big shout out and thank you to our Crown Council resource partner, eAssist, who also houses Practice Booster, which is a great repository of insurance coding information. If you'd like to take a deep dive even deeper into the codes that we've talked about today, you can scan that QR code for a 3-webinar series that Practice Boosters put together for the changes for 2023, and they go deep. As you say, Pam, in our seminar, they go way deep, as well as if you'd like to subscribe to their Code Advisor online resource with coding tips. That is a Crown Council benefit, so you're welcome to take advantage of that, and they've given you a promo code that'll give you a discount on those 2 items. Finally, if you'd like CE for today, you can grab your phone and scan that QR code. And that'll take you to a landing page where you can go ahead and fill out your information for today in order to receive 1 hour of CE credit for today's content. And if you'd like credit, that needs to be submitted right away. We're no longer allowed to issue credit way after the fact. So submit that today if you've participated in today's webinar. So again, thank you, Pam, for your coding and insurance expertise. And Stu, thanks for having us on
Steve.
Crown Counsel Live today.
You bet. My pleasure. We'll be back next week.
All right, perfect.
Thanks, everybody.
Thanks, everybody.
Bye.